The two drugs, because of their nature, one is a multi-kinase inhibitor, one is a cytotoxic, have different toxicity profiles. TES-102's toxicities are primarily bone marrow toxicities, neutropenia, thrombocytopenia. Neutropenia is pretty pronounced. In fact, 4% of the patients will have febrile neutropenia, which is pretty significant. We think about an oral drug, easy, but you do have some toxicities, and it happens actually earlier on. There are also some GI toxicities and fatigue that can happen in patients who get exposed to it on the longer term. Regorafenib on the other term has toxicities like hand and foot syndrome and diarrhea, hypertension, so the VEGF toxicities and the kinase inhibitor toxicities that also happen earlier on. Now, in terms of this patient, the patient was placed on regorafenib after a discussion with her oncologist, which I think makes a lot of sense. This would be the natural positioning for regorafenib. Patient could perform stats, failed 2 prior lines of therapy, and now gets to this level. You know, my personal experience with regorafenib has been pretty much placing it at the 3rd or 4th line of therapy. And when I look at my own experience and the patients I've treated over the last couple of years, we've had few patients who had CA responses, stable disease. We had many patients who did not respond to treatment. So it's what you would expect at this line of therapy. Most patients actually do not respond or respond well to treatment. For those patients who actually had a response, and when I say response, it's not, we almost never see significant shrinkage. You do see some shrinkage that wouldn't qualify a patient for what you call a partial response. You do see what we call minimal responses. And we see in some patients steep drops in the CA. In fact, I have patients who went for 6 months. My longest patient has gone for close to a year or a little bit more continuously on regorafenib. One of the things about regorafenib is its toxicity. Its toxicity has been a deterrent for some. And I think the concern is, and it's real, because patients are pretty beat up when they get to this point. They've had a lot of therapies, they're tired, and these toxicities can get quite amplified. But regorafenib's toxicities happen very early in the first 2 to 3 weeks. And in fact, the worst toxicities, so not just the toxicity itself, but its grade at its worst, happen in the first 2 to 4 weeks of the treatment. So I think it is essential to educate the patients really well about the toxicities, when to call. But also, in our practice, we bring the patients every week to the clinic. They don't have to see the physician. They can see the nurse practitioners. Occasionally, they can have a quick check by the nurse. But the first 4 weeks are very critical, and the patient has to be seen once a week for their follow-up. And that is one way to actually cut down on the risk of significant toxicities. In the second month of treatment, every 2 weeks, after the second month of treatment, patients will be seen on a monthly basis, because most of these toxicities would have been figured out with those adjustments. And the next question is, what dose do we start with? And the dose at this point of time that was defined by the correct study is 160 milligrams orally every day for 3 weeks in a row, then a week off. Most physicians, most oncologists in the United States use a different dosage. Some start with 80, escalate to 160. Others start at 120 and stick to 120. Others, like myself right now, in the absence of data, start with 160, knowing that 20% of the patients need that dose, will never actually require a dose reduction. We have a short amount of time for most patients with a PFS of close to 2 months. I don't want to play around with the dose without data, and then de-escalate. I don't think there's a right or wrong strategy, and we are addressing this question. There's a study called REDOS that's a large phase 2 randomized study that's looking at the question of start with the standard dose versus a dose escalation strategy. Good news is this study is about complete, and we'll be able, I'm hoping, to present the data at ASCO GI 2018 and help with the understanding, can we safely and effectively start patients at the lowest dose and escalate rather than start at the highest dose, where we know 80% of the patients will have to settle down at a lower dose.